Thank you very much for having me to Charles University. It is my first time here, but I feel a great affinity as for the School of Medicine and healthcare system. I've spent my entire career working in public hospitals. I started at Jacobi Hospital in the Bronx, New York, where I was an intern and resident, and then I spent the rest of my career at San Francisco General Hospital, which is the main county hospital in San Francisco, and basically provides care to underserved populations and minority populations. And as I'll talk about in a few minutes, this is a population in which maybe try to put that up a little higher. They're hard to hear in Texas. Okay. Is that better? And it's the population in which smoking remains the biggest challenge in the U.S. What I'd like to do is talk a little bit about some of the public health challenges of smoking, talk about why people smoke, and give you an overview about nicotine addiction, and then talk about some of the issues that are ongoing with respect to policy, especially FDA, product regulation, and some of the newer products that we're dealing with in the nicotine area. So let me see, where does this? I do consult with some pharmaceutical companies that are developing and marketing smoking cessation products. I have been involved as a paid expert in litigation against tobacco companies regarding nicotine addiction. So the public health problem broadly is shown here. Smoking is a problem worldwide. In the U.S., currently about 20% of people smoke cigarettes. Okay. Is this better? Yes. All right. Okay. In developed countries worldwide, about 35% of men and 20% of women smoke cigarettes. In developing countries, more men, 50%, fewer women smoke cigarettes. Smoking is still the greatest preventable cause of premature death. On average, a lifelong smoker has a 1 in 2 chance of dying prematurely from smoking cigarettes. And the average loss of life is between 7 and 10 years for a smoker. In 2000, it was estimated that there were about 5 million tobacco-attributable deaths around the world. This will be 10 million by 2020, about 400,000 in the U.S. So in terms of public health, there's very few areas where one can make as big an impact than if people could stop smoking. I said that the U.S. had a smoking prevalence of about 20%. In California, we're doing better. In San Francisco, probably Los Angeles, the average prevalence is about 12 to 15%. And that's because in California, there's been an emphasis on healthy lifestyle. There have been a lot of indoor smoking regulations. There have been public media campaigns. But I work at a county hospital, and many of you work at the county hospital too. And I want to show you a couple slides of data from our hospital when we try to look at smoking in our patients. The way I've done this, nicotine, and we'll talk about this later, is converted in the body to a breakdown product called cotinine, which has got, it stays in the blood for a long period of time. We measure it. So one study we did in 2006 was to take extra blood samples from 1,000 patients admitted to San Francisco General Hospital. These were left over from blood screening tests, and measured cotinine, and from that ascertained what the smoking prevalence was in the hospital. And you can see at San Francisco General Hospital, 40% were active smokers based on cotinine. 12% were either active smoking or heavily passive smoke exposed. So we had 62% of our patients were substantially exposed to cigarette smoke, compared to 12% for the city of San Francisco. So you can see when you're dealing with poor patients, you're dealing with minority populations, the smoking rates are no different now than they were in the U.S. in 1960. Here's a study that we recently published, which looked at children. We looked at 500 children, and in this study we looked at blood samples that were taken for routine lead screening, which is something that we do widely in our hospital population. And our kids in our hospital are mostly Hispanic and Black, with smaller percentages of white and Asian. What we found, if we looked at the cotinine concentrations, or the percent of the children who had cotinine concentrations above the cutoff for secondhand smoke, on average it was about 55%. I should say this population, half were under 3 years of age. So we're talking about children, and we know secondhand smoke is a major concern for children in terms of respiratory disease, asthma, ear infections. 55% were exposed. 90% of African Americans were exposed in this population. And then the right-hand panel just shows the average cotinine level. And we've made this observation, others have as well. African Americans have much higher levels, which we think is a combination both of more exposure and also African Americans in general, because the genetic differences metabolize cotinine more slowly, and the levels tend to be higher with the same exposure. But you can see that in a general public hospital population, smoking is not a problem that's been cured. It's a huge issue. Before I talk about this, I want to make a couple comments about tobacco-related diseases. You all know that smoking causes cancer, it causes heart disease, it causes stroke, it causes chronic obstructive lung disease. There are two other areas that I want to emphasize that you may not know as much about, but which I think are enormously important. The first is infectious disease. This is important. Smoking affects the lungs. It affects the ability of the lungs to clear organisms. It affects the immune system, the immune response. And it's very clear that cigarette smoking increases the risk of many infections, including pneumococcal pneumonia, Legionnaires' disease, meningococcal disease, periodontal disease, influenza, HIV. And the one that's probably most important, tuberculosis. First, I'll tell you an anecdote about TB, which I think is really fascinating. In the 1900s, in the U.S., most tobacco use was spit tobacco. So people chewed tobacco and they spit their juice in a can. There was concern in the U.S. about tuberculosis being transmitted by spitting tobacco juice. So this was part of the reason why the cigarette industry developed a safer way to take nicotine. So that you could smoke cigarettes, you wouldn't be spitting, and you wouldn't be transmitting tuberculosis. Well, it turns out cigarette smoking is a substantial risk factor for tuberculosis, both active and passive smoking. Richard Pito, who is a well-known epidemiologist from Oxford, did an analysis of the attributable causes of death from cigarette smoking around the world. And it turned out that the increased risk of tuberculosis is the major way around the world that cigarette smoking kills. So whereas cigarette smoking in the U.S. began as a way to reduce tuberculosis, it turns out it's become a major reason for tuberculosis deaths around the world. The second thing I want to talk about is acute coronary events, which are like heart attacks, unstable angina. There was an Institute of Medicine report in 2010, I served on that committee, which analyzed data precipitated by reports that when there were smoking bans in either states or towns or communities, there was a reduction in the number of heart attack admissions to hospitals. And we analyzed 11 or 12 studies, and it was pretty clear that it was pretty consistent, that when smoking bans were in place, heart attacks dropped by 30%. And I concluded that it's likely that there's a causal relationship between secondhand smoke exposure and acute coronary events. And it was also that this is a quick response, so it's something that occurs with short exposure. There have also been a number of biological plausibility studies. The most impressive one, I think, is one that was done in San Francisco, where people were exposed to secondhand smoke in a chamber for 30 minutes. And it was found that it activated clotting. It caused damage to endothelial cells, which are the cells that line blood vessels. It caused impairment of blood vessel dilation. And that these effects occurred for 24 hours. And then these effects were almost as great as with active smoking. So there's this clear biological plausibility. And the last, as I mentioned before, is that there are a number of reports where when you ban smoking indoors, there's reduced coronary events. So this data has got two implications. One is that if you use one with coronary disease, you don't have to ask them about smoking, ask them about secondhand smoke exposure, because if they're exposed, they have acute risk of a higher risk of events. And the second thing, it makes it much more compelling.
I'm still having trouble hearing out of this one here. Can we move this up?
Okay, and the second is that it's really imperative that we expand indoor smoking restrictions so that patients with heart disease are not exposed. These last two health effects that I talked about are not health effects from chronic smoking. So many smokers like to say, well, I know smoking is bad for me, but it's only bad for smoking for 20 or 30 years, and I'll quit before I get sick. Infectious disease doesn't work that way. Acute coronary events doesn't work that way. So there really is a short-term imperative to reduce smoking and smoking exposure. In the U.S. as around the world, for most smokers, quitting smoking is the single most important thing that they can do to improve their long-term health. And patients expect to be counseled about smoking, and this is really an imperative in all these practices. So I want to switch now and talk about addiction, basically why people smoke cigarettes. My background is actually pharmacology and cardiovascular disease, and I've studied nicotine as a drug for more than 30 years. And so my sort of paradigm thinking about this is shown here. Nicotine is what's responsible for addictive tobacco use, and addictive tobacco use is what's responsible for a projected 1/4 of the billion deaths in the world in the current generation. No one else stops smoking. I'm not going to be talking about tobacco company marketing or advertising or social factors, which are also important because my focus is really the drug. So I'm going to say that's going to be what I'll focus on. So we'll start to talk a little bit about the neurobiology of nicotine addiction. Let me just say it's very complicated. I'm going to give you the simple version. You'll hear more complicated parts of the story in some of the other speakers, I think. So the first is, what's drug addiction? There are two definitions that I like to use. First one's really simple, which is a loss of control of drug use, which means when you want to stop a drug or reduce the use of drug, it's difficult. Not impossible, because people quit all the time, but it's not easy. Sometimes people can't do it. For smoking, it takes, on average, 6 or 7 attempts of quitting before people succeed. So the loss of control of drug use. The second one, which I also like, is a disease of brain reward centers. So brain reward centers are those parts of the brain that compel behaviors that advance survival. So eating, drinking, sex behaviors. Drug abuse, not just nicotine, but others, hijack those centers. And so drugs become just as powerful, or seeking drugs, just as powerful motivators as sex or those other kind of behaviors. People want to take great risks to have these rewards, and so they're willing to risk their health, for example. So most smokers know smoking is bad, but the drug is so rewarding they have a hard time not smoking. So let's talk. And here's the example of loss of control of drug use in the U.S. There's currently 48 million smokers. Many surveys over the last 20 years show 70% wish they never started and would like to quit. About 30% or 17 million try to quit each year, as defined by at least one day of not smoking with the hope of quitting, and about 3% succeed. This is clearly loss of control of drug use. So let's talk about nicotine receptors and some of the neurochemistry issues. So here's a nicotine molecule, and I put it next to acetylcholine. Acetylcholine, as you know, is a neurotransmitter that's responsible for communication from one brain cell to the next. Like most psychoactive drugs, nicotine works because, or has its effects because it mimics the effect of some endogenous neurotransmitter or hormone substance. So nicotine binds to receptors that are meant for acetylcholine. And instead of having natural acetylcholine, when you smoke a cigarette, you can drive acetylcholine responses. Here is a slide, a sort of cartoon of a nicotinic receptor, which is where nicotine acts. Receptors are protein units that act like a key and lock. So something like nicotine or acetylcholine binds to a receptor, has very unique structure, so it binds just that substance, and then the receptor does something that activates the cell. So in case of nicotine, the receptor is like a channel, like a membrane in the cell. When acetylcholine or nicotine binds to the outside, it opens up the channel, and then ions go through, sodium ions or calcium ions, and then that activates some response. So that's when nicotine works. These channels are comprised of subunits. There are alpha subunits and beta subunits. In the brain, there are 9 alpha subunits and I guess 3 beta subunits. They're combined in various ways, so that most receptors have got some alpha subunits and some beta subunits. Some type of receptors have just alpha. And there are different type combinations of subunits in different parts of the brain that mediate different functions. The most abundant are alpha 4, alpha 5, alpha 2, and alpha 7. Beta 2 is one that's essential for self-administration in animals. Alpha 4, alpha 5, alpha 6, and I've heard recently alpha 2 moderates sensitivity to nicotine. Alpha 5, interestingly, is the one that in genetic studies has been the strongest predictor of dependence. So variation in alpha 5. Alpha 7 is possible in synaptic transmission. Alpha 3 beta 4 combination of cardiovascular responses. That's important because we have, I'm not going to talk about this, but we have the selective for alpha beta 2, which is thought to be most involved with addiction, like varenicline, which don't affect alpha 3 beta 4, so drugs that have effects on behavior without having cardiovascular effects. So it's possible to develop drugs that are very specialized receptors. So when you activate the receptor, the main effect is what's called a presynaptic effect. So it works on other neurons to augment the release of different substances by those neurons. So when you have nicotine, you see enhanced release of other things. And it acts on a lot of different things. This side is simple, but dopamine is released by nicotine and by every drug of abuse. Dopamine is key because that's a substance that is, whenever you do something pleasurable, if you're having a good meal, if you're having sex, if you're looking forward to having a fantastic afternoon doing whatever, dopamine is released. And all drugs of abuse release dopamine. So all drugs of abuse are perceived as pleasurable. Norepinephrine is released, which may play a role in arousal, appetite suppression. Acetylcholine itself is released, which may play a role in cognitive enhancement or better concentration of performance. Glutamate is released, which may play a role in learning and memory enhancement. Serotonin and mood modulation and appetite suppression. Beta endorphins and GABA reduce anxiety and tension. The idea is that nicotine can release these neurons depending on what the person is doing at the time. So people smoke and say, why do you smoke a cigarette? They'll say, the first cigarette in the morning helps me wake up, and it's like coffee for a coffee drinker. It perks me up, wakes me up. One of the longest measures of dependence is how many minutes after you wake up do you have your first cigarette. The shorter it is, the more dependent you are. And so it's a stimulant. They will also say that during the day, if they are fatigued and they can't concentrate or focus, a cigarette helps them perk up and focus and do the job better. At the same time, a person will say, if I'm stressed or anxious, a cigarette will relax me and make me less anxious. And then a cigarette prior to bedtime to help me relax and go to sleep. So it's really unique among the various drugs, and that has many different effects that seem to be opposed. But probably work because of these presynaptic effects augment release of hormones that are being released by the body anyway. The result of this is that smokers come to use nicotine to modulate their mood and their arousal. And so smoking becomes a very important part of life coping mechanism. And after smoking for years and years and years, it's hard to live without these ways to modulate mood and arousal. So if you want to look at the brain types of action, this focuses on the dopamine responses, which I said is common to all drugs of abuse. The action is in the mesolimbic system, and nicotine itself is thought to work mostly on the alpha-4 beta-2 receptors in the ventral tegmental area of the midbrain. This then activates the nucleus accumbens, where the dopamine is released by all drugs of abuse. And it's this circuit which is sort of the core circuit for nicotine reinforcement. Now let me talk about the cigarette as a device. We'll talk about nicotine itself. Why do people smoke cigarettes? Here's a slide that shows in 3 smokers who smoke a single cigarette, blood concentrations of nicotine in arterial blood, which is the open symbols, and venous blood, which is in the boxes. And I show this because this represents the effect of inhaling a drug. So when you inhale a cigarette, nicotine gets to go from the lungs into the heart, and it gets pumped out in circulation. So within about 15 seconds or so, it gets to the brain. Because of the so quickly, the nicotine concentration in that little bit of blood is pretty high. So it gets to the brain in high concentrations quickly. So the implications of this are several. One, that when you smoke a drug, you get a higher concentration of drug than you would say if you took it orally. It's almost like IV if you smoke it. 2, we'll talk about tolerance in a minute. You can overcome tolerance with high concentrations. The third is that effects are experienced quickly, and rapid reinforcement is known to promote drug addiction. The faster you get your reward for taking a drug, the more addictive it is. And the final thing is that it's titratable. So you can adjust how you smoke each cigarette to get just the effect that you want. So if a smoker wants more nicotine or less, they can take more or fewer puffs to really optimize delivery. So it's clear that smoking a drug is really the most highly addictive way of using it. It's true for cocaine and nicotine. It also means, we'll talk about other forms of tobacco, that smoking is the most addictive form of tobacco as well. So now the next key part about addiction is what's called neuroadaptation. So when you're exposed to a psychoactive drug of any sort, the brain adapts. It tries to normalize its function, so it's no longer disturbed by the drug. These are levels on the top of nicotine in the blood throughout the day in someone who's smoking, say, a pack a day. So while nicotine itself, if we look at a single cigarette, like in the last slide, levels rise and fall pretty quickly. If you're a regular smoker, nicotine levels up through the day. They plateau throughout most of the day, and they're even present in the morning when you wake up. So the brain is continually exposed to nicotine. When that occurs, like I say, the brain adapts, and adapts in a couple of ways. Here's the ultimate neuroadaptation slide. This is the Guinness World Record holder for cigarette smoking in a short period of time. So it's a guy named Stephen Sigmund who lived in what was Transylvania at one time, and smoked 800 cigarettes in 5 minutes. Now this is a lethal dose in anybody's standards, but this person was fine. And this is because of the enormous capacity of the brain and the body to adapt to effective nicotine. So there are two ways that adaptation is supposed to occur. One is there's actually a change in the structure and function of nicotine receptors. Here's a slide looking at brain sections. People have died, one smoker and a non-smoker, with a tracer that binds to nicotine receptors. And you can see that the brighter images, the yellow and orange images, mean more nicotinic receptors. And so in a smoker, there is on average 50% more nicotinic receptors compared to a non-smoker. So there's an upregulation or change of nicotinic receptor structure function. There's another area which is important, which is termed neuroplasticity, which means that when someone's a smoker exposed to nicotine for a long period of time, their brain changes their structure. So it's been shown in animals that the production of new genetic products, the change of protein expression, results in cell signaling, new circuits are developed. So it's really like new learning memory tracks. If you look at some of the genetic studies that have looked at the genes that predict the potential susceptibility to nicotine addiction, a lot of them are genes involved in cell signaling and learning and memory circuits. These circuits, the changes in brain receptors, at least in animals, go back to normal within a couple of weeks. These neuroplasticity changes, as far as we know, last lifelong. So once you're a smoker, you're really never the same. And there are many stories of people who have quit smoking for 10 years, had some special situation, had a cigarette, and within a week they're smoking a pack a day again. So these are long-term changes that are occur as a consequence of cigarette smoking. So when the brain adapts, that means that it's functioning normally again with nicotine. So we're not seeing, we have tolerance to many of the acute effects. And then when you quit smoking, you then have what are called withdrawal symptoms. So these are symptoms that are different from the acute effects. And it's things like psychological distress, both irritability, anger, impatience, anxiety, difficulty concentrating, so cognitive and performance impairment. This is a huge problem for someone who smokes while they're working. So if you are a writer and you always write while you're smoking a cigarette, I got a friend who was a writer, and when he quit smoking, he couldn't write for 6 months because he just couldn't function and concentrate properly. Huge problem with quitting smoking. Hunger, eating, and weight gain is part of nicotine withdrawal. Tobacco craving, and then which George Koo talks about, which I think is really important, is hedonic dysregulation. So to go back to dopamine, dopamine is involved in pleasure. Hedonia. When you stop smoking and you stop other drugs abuse as well, you have a pleasure dysregulation syndrome, or dysregulation. It's probably related to deficient dopamine release as part of the pulse mechanism. So here you have dysphoria, or sort of an off mood, depression, irritability, anxiety, and sort of the inability to experience pleasure. So things that are normally fun for you just aren't fun. You don't enjoy them. A single cigarette can normalize this. A person can say, I have a cigarette, also I feel normal again. These symptoms last for months. And as you know, in smoking cessation, the early quit rates in many treatment trials are really high, like 70%. But by 6 months, 3/4 of people relapse. And I think this is one of the big factors of relapse. People just don't feel right for months. They smoke a cigarette, they feel normal again. Now, I talked about nicotine, but you should know that it's not just nicotine that's involved in addiction. Cigarette smoking delivers a lot of other chemicals, and one important component of addiction, which is inhibition of an enzyme called monoamine oxidase in the brain. This enzyme metabolizes or breaks down catecholamines like norepinephrine and dopamine. This slide shows some images of monoamine A oxidase activity in a non-smoker on the top, in someone who's treated with translational, which is a drug that blocks monoamine oxidase on the bottom, so it's blue, so there's no activity, and then a smoker has about 60% reduction. This is important because when you reduce monoamine oxidase in the brain, and then you release catecholamines like norepinephrine or dopamine with nicotine, you get a bigger response. So in animal studies, it's shown that nicotine is much more addictive if you block monoamine oxidase. It's also more addictive because other things in the brain augment the effect of nicotine. So here's the classical dependence cycle that a regular smoker goes through. They smoke a cigarette, they have rapid absorption of nicotine, goes to the brain quickly, they have arousal, they have mood modulation, they experience pleasure. Then even from cigarette to cigarette, they become tolerant. So the first cigarette of the day is at the most impact. And then when you don't have a cigarette for an hour, you start having withdrawal symptoms. You get irritable, you feel a little bit depressed. You have a craving for nicotine, and then you smoke another cigarette or self-medicate, and you feel normal. So with this cycle, if you're a smoker and you're allowed to smoke ad lib, most smokers have a certain amount of nicotine every day, and it's pretty consistent day to day to day. These perks are optimized the nicotine to optimize their function. Now, later we're going to talk about harm reduction. So I want to just mention one of the early issues in harm reduction. You know, the idea behind harm reduction is if cigarettes are bad for you, is there some way to smoke where they're not quite as bad? And so in the 60s and 70s, because it was known that tar and probably nicotine were involved in adverse health effects, the tobacco companies started marketing what are called light cigarettes, which are cigarettes by smoking machines delivered as hard nicotine. And here's an advertisement for when they could still advertise them. So somewhere at the bottom, somewhere at the top. And an important thing to recognize about these cigarettes is that the nicotine in the tobacco is old. The reason that they're low tar relates to the smoking machine test. This is a smoking machine. It's basically a syringe that draws smoke from a cigarette. It draws out 35 milliliters in about 2 seconds, repeats that every 60 seconds until the cigarette burns down to a certain distance above the filter. That's the standard test. So the tobacco companies figured out that if they ventilated the cigarettes, either the paper or the filter, and you test by this kind of a machine, basically the syringe is getting a lot of fresh air instead of tobacco smoke, and the yields drop down. Well, the smokers learn two things. One is that some of the ventilation holes are in the filters, so a smoker can actually block the holes in the filter. The second thing is the faster you draw in, the less effective the ventilation is. So smokers automatically, without knowing anything about ventilation, compensate by taking bigger puffs, faster puffs, more frequent puffs, and because nicotine is in the tobacco, they easily compensate. So studies have shown there's no difference actually in exposure to nicotine or tar with light cigarettes compared to regular cigarettes, because addiction really drives receiving for nicotine. And there's been extensive analysis of the health effects, and there's no difference in health effects at all in people talking light cigarettes and regular cigarettes. So it was promoted for harm reduction to reassure smokers. It didn't do anything. So this was a big failed public health harm reduction. So before I leave addiction, let me just talk about another population which is interesting, which are light or non-daily smokers. In the US, especially California, there are a lot of people who smoke fewer than 10 cigarettes per day, who don't even smoke every day, but they can't quit. These people don't fit the classic addiction cycle. They don't have withdrawal symptoms, but they can quit. In this case, these are people who be smoking mostly for the primary reinforcing effects that I showed you. So the stimulation effect, its effects on mood. They're still addictive. We don't have good ways documented to treat these people, but this is a growing percentage of the California product smokers. We need to know about this. Another comment which I'll add to this, which you probably know about, is the population of cigarette smokers is different than the general population of people in Los Angeles or California. There's a high concordance with alcoholism, of drug abuse and cigarette smoking, depression, schizophrenia, Ph.D., anxiety disorders, bipolar disorders, all have much higher prevalence of cigarette smoking. If you look at depression, the history of major depression is much more common in smokers compared to non-smokers. The more dependent you are, the more addicted you are, the more likely you are to have a history of depression. And if you have a depression history, you're more likely to have severe, including severe depression. Now, there are many reasons for this. One hypothesis is that people are self-medicating with nicotine to help treat depression. There's also a shared genetic predisposition. There's effects of oxidation in the brain, which actually help depression. But the fact of the matter is, it's estimated that 40 to 50% of all cigarettes that are consumed in the U.S. are consumed by people with mental health disorders, either substance abuse or other mental health problems, which is a challenge because these patients are harder to treat. So now let me shift to the second half and talk about public policy things. Now, there are a lot of important public policy things I'm not going to talk about, but as you all know, taxation is a huge issue. The more expensive cigarettes are, the fewer cigarettes are smoked, especially for kids. Clean indoor air is really important. Media campaigns are important. What I'm going to talk about is sort of a newer area, which is product regulation as public policy. Again, I come from a pharmacology point of view, so that's what I'll talk about. The story began here, and this is a newspaper clip of David Kessler, who was head of the FDA. And this was on February 24th, 1994. He wrote a letter to the Coalition on Smoking and Health, stating for the first time the intention of the FDA to regulate cigarettes, in this case as a nicotine delivery device. Prior to this, FDA wanted nothing, and actually during this time as well, aside from David Kessler, no one else wanted anything to do with cigarettes. It's not a drug, it doesn't make it get better. The toxin, FDA wanted nothing to do with it. But Kessler was a pediatrician and saw smoking as a huge pediatric and public health problem, thought, this is something we should consider. Now, the background behind this, first of all, what a drug. So a drug is an article other than food intended to affect the structure or function of the body. The reason why the FDA seized on this is in the late 80s, 1990s, a lot of tobacco companies' secret documents were released as part of litigation. And what was found was, well, it was known that nicotine has effects on body structure function. We talked about some of the effects, the cardiovascular effects, affects mood. But the documents showed that the industry knew that. They knew nicotine was addictive, and they also had worked out optimal levels of nicotine to sustain smoking in their studies. So they figured out that a yield of 0.7 milligrams of a cigarette is what smokers need to maintain it. So all of a sudden, this is not just a product that might taste good. This is a pharmacologic issue. So that was part of it. And also, the document showed that the tobacco companies, not just blend by taste, they measure nicotine. They can extract nicotine, re-add nicotine, so cigarettes are highly controlled for nicotine content. So with that information, and what we knew about the pharmacology of nicotine was a drug by FDA definition. So in 1995, there was an FDA advisory committee. I was actually serving on that committee, which looked at the question, is nicotine a drug? and including whether nicotine in cigarettes and smokeless tobacco is a drug, and that these products are nicotine delivery devices under the Federal Food, Drug, and Cosmetic Act. So it was in this context that David Kessler says FDA should regulate this. So finally, in 1996, FDA asserted their authority to regulate tobacco. They said, we're going to regulate. They said what they're going to do. But then they were sued, and the courts in 2000 said you can't. Congress has not given you the authority to regulate tobacco. Well, finally, in 2009, Congress did provide it. So they passed the Family Smoking Prevention and Tobacco Control Act. And it was signed on June 22nd, 2009. And I'll talk a little bit about this act because this act is sort of the interface between pharmacology and public health. And so here's the signing ceremony for President Obama. So this act gives FDA the authority to regulate tobacco products and recognize the FDA as the primary federal regulatory authority with respect to the manufacture, marketing, and distribution of tobacco products. And so they developed a new branch of FDA called the Center for Tobacco Products, which is funded by tobacco companies. There's a tax basically that tobacco companies pay based on how much tobacco they sell. Some of the things FDA can do, they can promulgate tobacco product standards as opposed to better public health, which means they can mandate changes of constituents. There's a carcinogen in there that FDA says should be removed, and it can be. They can mandate that. The thing which interested me is they can also reduce nicotine yields of a product, so long as it's not reduced to zero. Now that gives us a huge opportunity, which I'll talk about in a second. The goals of the FDA law are one to use tobacco use, how to use tobacco to quit, to promote public understanding of the contents and consequences of tobacco use, and to develop a science base and begin meaningful regulation to reduce the toll of tobacco-related disease. And to date, FDA has done a number of things. Just to go through the list, they've mandated a minimal smoking age federally of 18 years of age. They've mandated a minimal pack size of 20 cigarettes, so you can't sell single cigarettes. They've banned free distribution of cigarettes. They've banned product name sponsorship in concerts and sporting events. They've banned flavoring except for menthol, which is still highly controversial. There was a menthol report, and they still haven't done all other characterizing flavors like strawberry or coffee or whatever. They're all banned. They've banned descriptors such as lights, so you can no longer market the cigarette light to it. Of course, the tobacco companies get around that by some are blue and some are red, so you can get a sense of what's light and what's not. But they can't explicitly say market light cigarettes. They've been involved in enforcing youth access restrictions, including inspection of stores. They've mandated health warnings on smokeless tobacco products, and they recently came up with a rule for cigarette packages saying that they had to have graphic warnings, which are pictures of bad things that tobacco does, like cancer, gastrostomies, and that's got to cover 50% of the package and cigarette and 20% of advertisement surface area. But this is not currently held on the courts, so it hasn't happened yet. But this was also passed. So that's what FDA has done. So what I've been interested in for many years is the issue of nicotine addiction and using product regulation as a way to deal with addiction on sort of a nationwide basis. So the assumptions behind this are as follows. One, nicotine is the addictive agent in tobacco products. We know that's true. People do not smoke cigarettes when they do. The second is that tapering drug use is a common approach to treating drug addictions. You know, we do this with heroin addicts with methadone. We do it with alcoholics with benzodiazepines. It's widely used. And so the idea is to reduce the nicotine content of cigarette tobacco gradually over time to lower the level of nicotine dependence to sort of taper people from dependence. Now, the original proposal, which we published in 1994, Jack Henfield, who was a colleague of mine, was based on preventing youth addiction. So, you know, at that time we were focused on the active part of it. And it's known that 3,000 children per day, people under 18, begin using cigarettes daily. So that matches, for the most part, people quit or die. This slide shows the cumulative prevalence of smoking by age. And the solid line is the first cigarette. So the median age is 14 or 15 for the first cigarette. The dashed line is daily smoking, which can be used as an indicator in youth of smoking. And that occurs in a median of about 18 years. And so what was seen here is that there's a 3-year gap between experimentation and addictive smoking. And when kids start smoking, they don't start because they're addicted. They start smoking because their friends are smoking, because they think it's cool, movies or books or whatever, but it's social. And then as they keep on smoking, they start experiencing the pharmacological effects, and they start experiencing withdrawal effects. And after a while, they start smoking not with friends, but by themselves, and then they become addicted. There's no way we can stop kids from experimenting with cigarettes. But the idea was, could we prevent the transition from experimental smoking to addictive smoking so they do not become addicted adults? So this was the idea behind a nicotine reduction approach. Here's the other part of kids. If you talk to kids about smoking, they all know smoking is bad. No kid now doesn't know smoking is bad for you. What they tell you is that, you know, I know, but I want to smoke with my friends. It's a good social thing to do. And I'm going to later, when I grow up and before I get sick. The problem is, and this has been studied, you know, you ask kids, are you going to quit? And then 5 years later, you survey them, and the majority say they're going to quit when they're 18, but 5 years later, most of them said they're going to quit, are now addicted and can't quit. So they think they can quit, but they can't because they're addicted. And there's no way that kids can really understand addiction until you're addicted. So the proposal that Jack Henfield and I published in 1994 in New England Journal of Medicine was to say, let's estimate a threshold for nicotine addiction. And we estimated 5 milligrams total nicotine per day. Typical pack-a-day smoker takes in 20 milligrams per day. And we worked out some issues in terms of the maximum amount you could get from a cigarette, and said if a person smoked up to cigarettes per day, if we reduce the content of nicotine per cigarette. So this is not light cigarettes that are ventilated. These are ones we just have nicotine. So normal cigarettes that contain 15 milligrams of nicotine per cigarette, smokers one. We say the cigarette can't contain more than 0.5 milligrams, in which case the most a smoker could get from that would be maybe 0.5 milligrams, or 1, you know, 0.5, I think. And then let's gradually reduce it over 10 to 15 years. So just to remind you that reduced nicotine content cigarettes are not these cigarettes. These are hard to compensate for. And the idea of something happened to the slide, I'm not sure what, but the idea is if you look at nicotine availability over years, the nicotine availability from tobacco gradually gets lowered as you take nicotine out of the tobacco. And if people need more nicotine, they can get pharmaceutical nicotine, or we'll talk later on about e-cigarettes, maybe. And then at a certain point in time, cigarettes become non-addictive, and people can either stay on other forms of nicotine if they're addicted, or they can stop those or whatever. So it's sort of like what we do with methadone. So that's the approach. The first criticism of this was that people are compensated, they're going to smoke 1 million cigarettes. And so I want to show you some data from a study we did trying to look at, is this feasible? So in our study, you get cigarettes, usual cigarettes, and then switched on a weekly basis in this study to cigarettes with 12 milligrams, 8, 4, 2, and 1 milligram. And then we followed them for 4 weeks. This was like a pilot study. What you can see is people do start smoking a little more cigarettes when you start reducing nicotine content to try to compensate for less nicotine. But then by the time they get down to the lower cigarettes, they don't, because they realize, I just can't get the nicotine. The cigarettes aren't very satisfying. And so they're beginning to sort of lose their need for nicotine. You can also see in this slide, in the 4 weeks after they're back to their own cigarettes, they smoke less. So this was the first example where it seemed like we reduced the amount of people that want to take in by tapering their nicotine intake. And here's a slide with codeine, which is basically a nicotine breakdown product, showing that as you reduce nicotine content in cigarettes, codeine levels dropped. When they're back to their own cigarettes, it rose again, but only to about half a baseline. And then we also looked at carbon monoxide and carcinogens, all those things. There's no evidence of any increased exposure. So there's no evidence that people were compensating in a way that would make cigarettes more harmful, but this seemed to be a way to reduce the level of nicotine addiction. And this would be something that could be mandated by the federal government. And there was a second larger study we published this year. And so our conclusion is this point, regulation of nicotine content of cigarettes and use of a nicotine reduction strategy to prevent or reduce the level of nicotine addiction appears to be safe and feasible. And it's something FDA is taking, and there's a lot of science ongoing now to try to look at this question. So now I want to shift and talk about some other nicotine devices. There was another Institute of Medicine report about 10 years ago that looked at the question of harm reduction. We know cigarettes are really bad, but people are addicted to nicotine. So is it reasonable that people use other products besides cigarettes to reduce the harm of smoking? And of course, consideration what is it that causes disease of cigarette smoking? And here's a list of some of the major toxic constituents of tobacco smoke. There are thousands of constituents. So oxidizing chemicals are things that damage blood vessels, activate platelets. There's a huge oxidative load in fresh cigarette smoke. Polycyclic aromatic hydrocarbons and tobacco-specific nitrosamines are potent lung carcinogens. There in the smoke. Carbon monoxide, is a problem for people with cardiovascular disease and lung disease, problem in pregnancy. There is nicotine, which has some effects. BI and acetylcholine are very potent alkylating agents that they cause an inflammatory response. They cause cell damage. And particulates themselves and smog cause serious cardiovascular problems, lung inflammation. Nicotine itself is thought to be a relatively minor component of this risk. I make a statement that nicotine, in addition, combustion products are responsible for most smoking-related disease. The main epidemiology data that I would use to support this is in Sweden. The use of something called snus. And I'll talk about snus in a minute. But snus is a smoke of tobacco and pouches that people put in the mouth. In Sweden, it's manufactured to be very low in carcinogens. And it's very popular among Swedish men. 30 to 40% of Swedish men use it. They use it all day long. They have nicotine levels that are just as high as cigarette smokers. And the epidemiology shows that Sweden, and they use it instead of smoking, so cigarette smoking rates are lowest. Sweden has got the lowest lung cancer rates in the world among men. And the epidemiology, the only cancer that's increased is pancreatic cancer. There's conflicting evidence about cardiovascular disease, and most studies show no increase in cardiovascular disease. So nicotine is not totally benign. We think that the risk of nicotine itself is probably less than 10% of the total risk of smoking a cigarette. So it's mostly combustion products. So that's led to tobacco companies beginning to market, and other manufacturers market substances that deliver nicotine without combustion products. And so we'll talk about some of those products. So first I would just go through what a cigarette compared to other tobacco products. So a cigarette is basically shredded tobacco in parts with flavorings and other ingredients. wrapped in paper, and usually attached to a filter. Cigar is darker tobacco, different blend, and it's wrapped in tobacco leaf. And so you probably know this, but there's a lot of different kinds of cigars. There are little cigars that are like cigarettes, inside cigarettes, smoke like cigarettes. They offer filters. There are cigarillos, which are bigger, and then there are huge cigars. Quite different epidemiology of use and health consequences differ as well. Pipe tobacco is a variety of use types and heavily flavored for aroma and taste. And then snuff is sort of ground tobacco, often flavored, that's put in your mouth. I'll show you that in a minute. So here's some pictures of the products. Cigarettes, obviously, in the top left, cigar under that. Nasal snuff is a very fine tobacco that you actually snort in your nose and absorb nicotine very quickly. It's not used in the U.S. It's used more in the UK, and it was more popular in the last century. Moist snuff is something that's moist tobacco. You put that in your mouth for like 30 minutes, and you absorb the same amount of nicotine as taking 2 or 4 cigarettes. The moist snuff on the upper right are in sachets or pouches, and snus is like this too. So instead of having all the loose tobacco stuff in your mouth, you put little packets in your mouth. It's cleaner. You absorb nicotine from that. All compressed products, I'll talk about in a minute. BDs are widely used in India and Indonesia. Those are flavored cigarette tobacco that are rolled in small cigarettes. It's a huge problem in those countries. And then there were alternative smoking products marketed for a while, but not marketed now. But these are ones that supposedly were low in carcinogens, they were low in nicotine, they were not successful. So I want to talk about a couple. First is snus, which is now being manufactured in the U.S. Tobacco, and that is passed away to countries. So it's got lots of nicotine, but not so much carcinogens, and it's being marketed by Altria, Reynolds, other companies, as an alternative to cigarette smoking and a way to get your nicotine with less carcinogens. There is a huge public health debate now about smokeless tobacco like this. The harm reduction people say if people switch to this instead of smoking cigarettes, the health consequences of smoking would go down by 90%. The people who are advanced that say this maintains the normality of tobacco use in general. It's used by people when instead of quitting cigarettes, they'll just use this when they can't smoke cigarettes. It still has some potential risks, like pancreatic cancer, maybe oral cancer. So there's a huge debate in the public health field about the role of smokeless tobacco. These are dissolvable products, which is probably lower in risk. These are very finely powdered tobacco products, and they come in lozenges like orbs, they come in strips, they come in sticks that you can suck. And these are products where basically you swallow the tobacco. It's very finely ground. They got relatively low nicotine yields, low carcinogen exposure. There's not much penetration. Not many people like these, probably because they don't get much nicotine. But these are on the market and are being promoted by the industry as an alternative to smoking. Hookah, what I talk about, not because this is the industry, but because it is widely used. As you probably know, hookah is a device where you put there's a charcoal briquette on top, and then you put hookah or water pipe tobacco, which is mostly dried fruit with maybe 10 or 15% tobacco, and you inhale it through water. It cools the smoke, and it's often smoked, often shared by people, smoked over 40 to 60 minutes. It's often used in hookah bars. It's very popular in the Middle East, and it's also fairly popular in college campuses and things like that in the U.S. The perception by many people is that the water filters out the carcinogen, nicotine. But It doesn't. We've studied this extensively. You know, if you smoke hookah, you get about the same as smoking 50 cigarettes worth of nicotine. You get substantial carcinogen exposure. But people don't smoke hookah all day long. Generally done on such a situation like on a Friday, Saturday night, it's done in a hookah bar, it's shared with a bunch of people. So in the U.S., I'm not convinced that this is a problem. In the Middle East, it is. The Middle East is epidemiology relating this to cancer because people use hookah extensively every day. In the U.S., it's got the potential to cause disease, but I don't think that from most of us, substantial risk. Now, Lung Association has said that this is an emerging deadly trend. I don't agree with that, but this is what some public health people say. And I'm going to end talking about electronic cigarettes. So this is a cigarette that looks like it's a passive device, looks like a cigarette, feels like a cigarette, doesn't combust. You inhale it and get a nicotine. It's got three components to it. It's got a cartridge that contains nicotine solution. It's got an atomizer chamber that atomizes the solution, and it's got a rechargeable battery. And it's a smart chip. So when you breathe in, it activates the smart chip, it activates the atomizer, and it turns on a light at the end, looks like a cigarette. This is very widely used. There is a huge public health debate about this, about whether it should be banned. And the concerns about these are there's like 50 manufacturers, all small companies. There's no quality control. There's a small amount of carcinogens. Nitrosamines are much less than cigarette smoke. There's concern about accidental ingestion by children and about youth becoming addicted to these products and becoming smokers later on. There's also an alternative side which says this is nicotine is much as harmful than smoking. Many smokers like this. Many smokers try to use it to quit smoking less. And so there's a huge debate on this as well. I think FDA is not trying to regulate this yet, but if they did regulate this, would be a very promising way to provide alternative nicotine. So because my time is almost, I'm not going to talk about but I'm going to end talking about the tobacco end game. This is something you should know about. So this is something that's discussed in countries around the world. Is there a way to eradicate or reduce to minimal levels the use of combustible tobacco products? There's recent community in Michigan that I attended where this was extensively talked about. And these are the things people are talking about for the worldwide end game to really get rid of tobacco. First is prohibition. Robert Proctor wrote a book about the tobacco industry and harm advocated, saying that any product that was as harmful as tobacco would be prohibited by any country. And he argues that we should try. Well, I don't think that's feasible. Tobacco-free generation is something that's being considered in Singapore. This is an approach where cigarette sales are restricted by age. So at a certain point, no one, say 18 or less, can buy cigarettes. So older people can smoke and buy the cigarettes, but no one under 18 can buy cigarettes or can be given cigarettes. There's the capacity to give cigarettes. So in time, they'll get a generation who's smoke-free. Thing lit is something that's being talked about in New Zealand, which is basically to restrict the quota of tobacco products that can be imported into the country over 10 or 15 years. The market is one which says the government basically takes responsibility for all marketing of cigarettes. Tobacco companies can't. They can make cigarettes. They can't control advertising. That's talked about in Australia. Some people talk about prescription-only tobacco. None of these are thought to have feasibility. The one that comes out as the one that's most feasible, probably in the U.S. and around the world, is nicotine reduction. And with these cigarette stuff, if these cigarettes are really safer than cigarettes, what you could do is reduce the nicotine content of cigarettes over time. You could have heavy taxation on cigarettes. You could have less taxation on e-cigarettes. You could basically shift the whole nicotine market. And so that's something which is also being talked about. So this is just sort of things that you might hear about if you get rid of the whole combusted tobacco. So I want to end with these with quote and magazine pictures. So the quote is from a Philip Morris tobacco researcher many years ago. And cigarettes should be conceived not as a product, but as a package. Product of nicotine. Think of the cigarette's pack as a storage container for a day's supply of nicotine. Think of a puff of smoke as the vehicle of nicotine, and the cigarette the most optimized dispenser smoke. This was given in the 1970s by Philip Morris, long before FDA ever thought about regulating. But you can see that we're really talking about, in a sense, the tobacco industry being the most successful pharmaceutical industry ever. They marketed nicotine in a way, they know it's a drug, and now science is really caught up, and we're treating it and understanding the drug delivery system. My last slide is this, which is 1984. I just love this. You know, there's a Time magazine where the main story was cholesterol and how eggs are bad for you and how you got lowered. It's because of cardiovascular health. Not a single mention of smoking in the back part. Lucky Strikes again. There's Lucky Strikes, which is also not available now, but really shows the attitude that a lot of medicine has had. We spend enormous amounts of money on lowering cholesterol, on treating mild hypertension. None of those resources are available for cigarette smoking, but the benefit of cigarette smoking far exceeds those others. So thank you very much for your attention, and thank you for inviting me. Please hold on for a second for questions. Okay, so you chat people we can hear you. We do have time for questions. Maybe I'll start with the first question, with the question about filters. Does filtering help? Is maybe that's where the secondhand smoke is bad? Is it because it's not filtered, or is the filter just really not that important? It's never demonstrated that filters help. They do filter out some substances like tars, but you don't have any data from the pre-filter era. On the other hand, filters are a huge environmental contaminant. There are millions of cigarette filters all over, in our waste areas, in our rivers, and so there's a lot of concern about filters carrying a lot of tobacco toxins in our environment. But the definitive study on whether filters make a difference has not been done.
You had a question, and we'll get Dr. Rowden.
Okay.
I wonder, I haven't heard anything about the strategy of trying to pay the tobacco companies not to grow tobacco. Actually, the history of paying farmers not to use their field for certain purposes. Right?
I don't know anything specific about that. Certainly, if that were done, it would also be pretty limited to one country. There are some countries, the biggest tobacco producing countries in the world are China, Brazil, India, and the U.S. Huge part of their economies. I'm not sure that you could ever get the money to replace economic profits.
Other questions?
Yeah, you did have a question. I was asking about the kids have no children when they start smoking, and in particular, why they start smoking. Was there anything given to the fact that parents are smoking also?
Yes, parental smoking is a very strong predictor of childhood smoking, and it probably works both in terms of what's perceived to be normal behavior in the family, and there's also evidence that prenatal or childhood exposure also influences the likelihood of becoming addicted later on. But that's a factor, although the stronger factor actually is peer smoking. So that if you happen to hang out with kids who are smokers, you're much more likely to become a smoker. That's even stronger than the family smoking.
So your personal opinion, do you think that smoking is a disease? Of course, we can make it smoke.
So the question was, is smoking a disease?
It depends what you mean by a disease. The smoking per se, if you think of addiction as a disease, it certainly is a process that leads to disease. It's still an addiction. It certainly can be conceived of as a brain disease, being an addiction. But the reason I hesitate about that is what if nicotine were totally safe? And say people were smoking cigarettes and smoking cigarettes for lifelong, and they're addicted. Would that be a disease? I'm not sure, even though. So it's not a disease in terms of medical disease, but it certainly is in terms of addiction being a brain disease. I sort of didn't answer your question directly.
Charles, do you have a question?
I just was wondering if you could just discuss briefly about the possibility of different tobacco products in various countries with different ranges of nicotine that are present, if that's available. And certain countries that have lower levels of nicotine are found in their cigarettes, so that we do see a decreased trend for smoking.
I don't know of any data about nicotine content. We've studied data from different countries. The nicotine content of the tobacco is pretty much the same. What does vary, however, is the type of tobacco used and the carcinogen generation. For example, in comparison to Chinese smokers and U.S. smokers, nitrosamines in Chinese are much lower in the U.S. And lung cancer rates in Chinese smokers are lower than the U.S. That's because of different tobacco blends that are used in different curing processes. So I think tobacco-related disease is different. I'm not aware of nicotine content being different.
Thank you very much for a great talk, very inspirational.